at hemostasis. We've looked at the process of hemostasis. We've gone through primary hemostasis, secondary hemostasis. We've gone through the control of these mechanisms, and we also looked at the fibrinolytic system. So today we are going to look at disorders of hemostasis. Today in particular, we'll be looking at von Willebrand's disease. So as we go on, we'll see. So disorders of hemostasis, that's what we are going to look at today. So there are various ways they try to classify hemostatic disorders. Some try to classify it based on there are so many ways that it can be classified, but broadly I choose to group it like this for clarity. Disorders of hemostasis that has to do with platelets, disorders of hemostasis that has to do with vessel wall, and then the disorders of hemostasis that has to do with the coagulation pathway, which we have looked at also. So we are going to zero in on the disorders of hemostasis that has to do with the coagulation pathway. So, and under this sub-classification, hemostatic disorders can also be classified into inherited coagulation disorders. Okay, it can be acquired coagulation disorders, can be acquired consumptive coagulopathies. So we are going to pick one or two from each of these sub-classifications of coagulation pathway to use as an example for our learning. So we are picking von Willebrand disease from the inherited coagulation disorders. Okay, so today we are going to basically look at von Willebrand's disease. We are going to look at the outline of our study. We are going to look at the historical background of von Willebrand disease, the pathophysiology and the classifications, biosynthesis function, clinical and laboratory diagnosis, management strategies, acquire von Willebrand disease. So we're going to look at some aspects. We'll be talking about some aspects of von Willebrand disease. So historically, von Willebrand disease was first reported by Eric von Willebrand, who described a large family with a severe bleeding disorder from the island in 1926. Okay, he was able to establish some differences between what he observed and what they have been used to, or what they have also observed with those with hemophilia. So he observed that there are differences in the bleeding pattern of this type of patients from the classic hemophilia patients. So he discovered that these patients, they don't usually have that joint bleeding that are prominent or pronounced with hemophilia. And he observed that this class of patients with this bleeding disorder also experience the presence of mucosal bleeding. Then the patient that was used for this clinical study, for this observation, later died during her first menstrual period because of heavy bleeding. So they observed in a family that there are some severe presentations of bleeding that are not quite very similar to the classic hemophilia. So they noted it, and then with that, they started doing some further investigation, study the family history. So when they now go back to study the family history of this index case, the girl that had a very severe menstrual bleeding, manifested as a very severe menstrual bleeding, and during her fourth menstrual cycle, the fourth time she's observing her menses, she died from due to heavy bleeding. So this is the family tree of the lady. So when they now trace it back, taking the history of the parents and grandparents to see if there were some of them that have actually presented with such clinical bleeding. Okay, you can find out from their history, you can see the two parents, their great grandparents, you can see that they are quite carriers of this gene, which they continue to pass that down to the family tree. So there is a family history of bleeding in this family. Yeah. So, oh, so that is what we can take from that aspect of the history. So, as an overview, as a summary to describe what is the disease all about, what is von Willebrand disease all about. So, von Willebrand disease, we say, is an autosomal mucosal bleeding disorder caused by deficiency or dysfunction of von Willebrand factor. When you come to the first term we said here, autosomal mucosal bleeding disorder, you observe that it is classically different from hemophilia, which is a sex-linked bleeding disorder. So this is an autosomal mucocutaneous bleeding disorder, and it is caused by the deficiency or dysfunction, the absence or malfunction of the gene called von Willebrand factor, a factor called von Willebrand factor. Okay, we have both quantitative and structural abnormality, okay, led to decreased adhesion by platelets to injured vessel wall, causing impaired primary hemostasis. Now, you go back to our lecture on primary hemostasis, you recall the function of von Willebrand factor in initiating the initial response of platelet adhering with von Willebrand factor in the primary hemostatic mechanism. Now you take back your mind, assume a situation where this von Willebrand factor that is quite necessary to initiate the first stage of coagulation, the primary hemostasis, the adhesion of platelets to von Willebrand factor. Either the quantity is reduced or that the structure is structurally abnormal. So you find out that it will affect the coagulation process very drastically. Okay. So von Willebrand disease is the most prevalent of the congenital bleeding disorders and is found in approximately 1% of the population. It affects both sexes because of its autosomal dominant inheritance pattern. It affects both sexes because it is an autosomally dominant inheritance pattern. Some of these pictures you can find by the side there are pictures of how von Willebrand disease can manifest in somebody. The clinical presentations of von Willebrand disease can manifest in the form of heavy menstrual bleeding, can manifest as bleeding after tooth extraction, or bleeding after injury that's unable to stop. It can also manifest as mucosal ecchymosis and tachia in the skin. It can also manifest as nose bleed, even GI bleeding. These are some of the clinical presentation of von Willebrand disease. So we say that von Willebrand disease is the prevalence is 0.6 to 1.3% in unselected individuals. Okay, by von Willebrand concentration up to 1/20,000 of population seek assistance for von Willebrand disease because of von Willebrand disease hemorrhage. Okay, clinically, just like we're talking about in the first slide, we have mucocutaneous bleeds. usually traceable to events such as surgery, tooth extraction, or falling down trauma. Okay, we are still going to go down to the various types, but for now, von Willebrand disease type 3, in type 3, there is complete absence of von Willebrand factor, and if a patient is presenting with this type of von Willebrand disease, it adds to the spontaneous anatomic bleeds when there is surgery or wound or trauma. Severity varies over time and within kindred. Symptoms intensify by non-steroidal anti-inflammatory drugs, okay, and reduced by OCs, okay. Symptoms disappear in third to third trimester. That is for pregnant women who have von Willebrand disease. The symptoms seem to disappear because of the hypercoagulable states of pregnancy. Symptoms may reappear postpartum. These are some of the clinical findings with patients that present with this disorder. Okay, we've talked about von Willebrand disease, how they present clinically. There's another factor to it, the von Willebrand factor. Okay, the von Willebrand factor is a multimeric glycoprotein whose molecular mass ranges from 500 to 20,000 kilodaltons. Okay, it's present in the blood plasma at the concentration of 0.5 to 1 milligram per dl and the subendothelial matrix, as well as storage granules in endothelial cells, that is the Weber palette bodies, okay, and also in the platelets, the alpha granules of platelets. It mediates platelet adhesion and aggregation at site of vascular injuries and carries coagulation factor 8 in the circulation. This is what we have already discussed earlier when we talked about primary hemostasis, that during the process of primary hemostasis, there is this protein we call the von Willebrand factor. Okay, that von Willebrand factor during the process of coagulation at the site of injury, that von Willebrand factor platelet adheres to von Willebrand factor. Either the platelet adheres to von Willebrand factor or it adheres to the collagen in the subendothelium of the blood vessel. So platelet adhering to von Willebrand factor initiate shape change of the von Willebrand factor and release of von Willebrand factor granules and the subsequent aggregation that happens and the follow-up of secondary hemostatic coagulation mechanism. So I will also try now to say some of the biological characteristics of this von Willebrand factor, its concentration in the plasma, that it is a multimeric glycoprotein. So it is a multimer of glycoproteins. We are still going to look at the structure of this glycoproteins. Okay, so every proteins are produced from the gene. Okay, so the von Willebrand factor gene, there is a gene where the proteins are being produced. So the von Willebrand factor gene consists of 52 exons that spans 178 kilobase pairs on chromosome 12. That is where the gene for this protein is located. The translated protein is a monomer, okay, monomer of 2813 amino acids. Then they are released as monomers. After glycosylation, they form diamers that are transferred to the storage organelles. Okay, the storage organelles, the Weber pellet body and platelet alpha granules, where the diamers now polymerize to form numerous multimers. So the protein is released as a monomer, okay, which forms after glycosylation, forms diamers and are transferred to the storage organs where the diamers will now polymerize to form the multimers, the von Willebrand factor multimers. Okay, At the time of storage, a signal sequence and a propeptide known as the von Willebrand factor antigen 2 are cleaved so that the mature monomer, clearly polymerized, consists of 2050 amino acid. Okay. So von Willebrand factor cleaving protease cleave the large, ultra-large von Willebrand factor multimers of the Weber palette bodies at their moments of release into monomers of various sizes. So during the process, after the von Willebrand factor has been stored in the storage organ, okay, if in the event of any injury that they are being released from these storage organs, they are multimers, and that multimeric nature of the von Willebrand factor makes them a little bit more adhesive, so they can adhere to large platelets volume. So because of that, during the process of their release, a protein called the ADAMTS13 also helps to break them down into monomers, so to reduce their adhesive properties, so that the process will be under check, sort of. Okay. So this structure that represents the von Willebrand factor, given the domains, the genetic domains, the amino acid sequence, okay, the cDNA sequence also. When you look at the diagrams, you can see the first one here is the protein structure of the von Willebrand factor, mapping out various segments. When you look at this one tries to show us the domains of the von Willebrand factor. Each of these domains, the functional domains, okay, like you have here, for example, that collagen binds to von Willebrand factor is at this A3 domain. Okay, so these are the functional domains of von Willebrand factor, where they bind to their ligands. You can see the glycoprotein 2B3A. This is where it binds with von Willebrand factor, and then that von Willebrand factor also, we say that von Willebrand factor also protects factor 8, okay, from degradation in the circulation. That is because factor 8 is able to also bind with von Willebrand factor here, so that its half-life can be a bit extended. So this is also the cDNA sequence, that is the nucleic acid sequence of the von Willebrand factor. Okay, so any problem, mutation, molecular problem at this point in the sequence of the DNA will result, of the cDNA result in type 2N von Willebrand disease, and that is corresponding to this domain of the von Willebrand factor. Can see any genetic malfunction or mutation at this point will correspond to problems with platelet binding of von Willebrand factor. Okay, so this is what this diagram is trying to depict, trying to map the various domains, the functional domains, and then the cDNA sequence showing the specific areas of the von Willebrand von Willebrand segment of the cDNA where we have mutations or molecular abnormalities in the von Willebrand factor gene. Okay, this is also a more elaborate diagram trying now to zero down to the domains of the von Willebrand factor, the monomer. This is just a monomer of the von Willebrand factor with its domains, functional domains, where it binds to its ligands. You can see the different domains are arranged in the order D, A, D, B, C. Okay, you can see it down here, starting from D1, D2, D prime, D3, A1, A2, A3, D4, then B, and then C. Okay, the domains representing the propeptide and with the D1, D2 domain representing the propeptide, and the remainder corresponding to the mature VWF subunit. So this is the propeptide unit of the So each of the function of von Willebrand factor, can be traced to the domains, the point at which the binding occurs. So for binding of factor 8, heparin binding site is at this D prime domain, and any abnormality mutation around this place will give us what we call 2N von Willebrand disease. Okay, any mutational abnormality that causes this domain to malfunction will give rise to the type of von Willebrand disorder we call type 2N. Okay, so when you come to this domain, this A1, A2 domain, you can also see this is glycoprotein 1B binding site, heparin collagen binding site, where they bind to von Willebrand factor. So you can see also another collagen binding site. So any mutational abnormalities on this A domain will give us type 2B or type 2N or type 2A von Willebrand disease, depending on the ligand that is affected. So this is D domain, and then this is glycoprotein 2B3A. So, okay. Then any abnormalities in this domain will give us 2A, 2M. We'll still come to discuss on the various types of von Willebrand disease. So we say that the von Willebrand factor is a multimeric glycoprotein. So we're going to look at the monomer which we just saw, the domains of the monomer. So each von Willebrand factor monomer has 4 functional domains, as we have seen, that bind factor 8, platelet glycoproteins, platelet glycoprotein 2B3A, and glycogen and collagen, as we've seen in the diagram. Upon release from intracellular stores, the Wabbai palette bodies, alpha granules of platelets, von Willebrand factor forms a complex with coagulation factor 8. Von Willebrand factor protects factor 8 from proteolysis, prolonging its plasma half-life from a few minutes without von Willebrand factor to 8 to 12 hours with von Willebrand factor. So you can translate that to the management of hemophilia. Okay, so we say that this von Willebrand factor, okay, the gene for this von Willebrand factor is located at chromosome number 12 at 12p13.3, p petit, short arm, that is located at the short arm of chromosome 12 at position 13.3. It produces 2050 amino acid monomer in endothelial cells and megakaryocytes, polymerizes to 20 Daltons storage multimers in the alpha platelet granules endothelial cell Wabbai palette bodies. The plasma concentration, we have said earlier, the half-life is 12 hours, partially digested by von Willebrand factor cleaving protease, that is Adam TS13. Okay, loose coil 20%. Okay, all right. So these are some of the description of this. Okay, so we are going to look at the synthesis, assembly, and release. We are not going to go into too much details of this process. I'll leave that to your private reading. Okay, it's quite a huge complex pathway. We're just going to look at the pathway of the process from this place to this place, from this place to this place. So von Willebrand factor is produced in endothelial cells and megakaryocytes as a single polypeptide of 2813 amino acid. During synthesis, von Willebrand factor is subject to various post-translational modifications, including furin-mediated separation of the propeptide and glycosylation. Crucial to the von Willebrand life cycle, glycosylation starts in the early phase. We are going to see a diagram that represents this process. Indeed, within the endoplasmic reticulum, The enzyme oligosaccharide transferase mediates the attachment of a core 14 saccharide unit to asparagine residue within the developing polypeptide chain. You know, this is real biochemistry. So different studies reveal that the pro-von Willebrand factor subunit carries 17 N-link carbohydrate structures, 4 being located in the propeptide and 13 within the mature unit. Further along the synthesis pathway, the N-link glycans undergo maturation, whereas 10 O-link glycans are also added. Okay. Okay, storage organelle formation, because it has to do with the synthesis of the von Willebrand factors. Von Willebrand factor is transported to storage organelles in both megakaryocytes and endothelial cells. Okay, the endothelial cells and platelet granules differ from each other in their dependency on von Willebrand factor for their formation. Alpha granules can form in the absence of von Willebrand factor, whereas the generation of Weber-Palade body is strictly von Willebrand factor dependent. So that's the reason, more reason why this von Willebrand factor are being stored in this process, in these structures. Also, during the process of release. Okay, basal and regulated secretion of von Willebrand factors. Okay, during the process, there are two pathways of release of von Willebrand factor from their storage organs. Either there is an activation, like in wound, that will activate, that will give signal for the release of von Willebrand factor, or just constitutively, normally, without any trigger, von Willebrand factor can also be released from the alpha granules of platelets. I think alpha granules release von Willebrand factor predominantly upon platelet activation. Okay, endothelial cells combine basal and regulated release of von Willebrand factors contents. Okay, of release of Weber-Palade contents. Okay. Following its release in circulation, von Willebrand factor is ready to function. It's a molecular carrier for factor 8, recruiter of platelets upon vascular injuries at places of injury. Okay, let me see. The main determinants for this inter-individual variation most likely originate from different glycosylation patterns, in particular the presence of blood group ABOH structures appears to explain a large proportion of variations. So that's von Willebrand factor also shows some variations in individuals, and it has been linked to the blood types of individuals. Something I'm looking for. Okay, that's the image I'm looking for. So this diagram tries to show us the pathway for the synthesis of von Willebrand factor. As you can see at this side, this is the cell structure from the nucleus down to the cytoplasm, cutting the cell membrane, then outside into the plasma. So you can see the Golgi apparatus of the nucleus of the Golgi apparatus. Then, okay, at your left or your right, at your right hand, endothelial reticulum. Okay, you can see what is happening there. The gene, the messenger RNA translation and glycosylation occurs at this level of endothelial reticulum. Okay, so going down to C-terminal and dimerization. Okay, at this point, at the Golgi apparatus, we're having N-terminal multimerization, carbohydrate processing. It's happening at the Golgi apparatus. Okay, leading to the production of diamonds of von Willebrand factors. Then when you go down to the Weber palette bodies, okay, the production of multimers and all that happens. So upon for the process of release of von Willebrand factor, this is the constitutive pathway of release of von Willebrand factor, okay, from the Weber palette bodies of the endothelial cell. This is the constitutive release through this pathway without any activation. Okay, it can also, the Weber palette body, as we read, can also release von Willebrand factor through activation. If it is activated, can also release von Willebrand factor into the plasma. Okay, so we are going to look at how does the pathophysiology of von Willebrand disease, von Willebrand disease, von Willebrand factor gene. So all these terminologies revolve around von Willebrand factor, what causes it, how does it manifest, and all that. So the pathophysiology of von Willebrand disease. Okay, so I think under this pathophysiology, we'll be able now to also show the various types, because the various types are actually von Willebrand disease. So while discussing the pathophysiology of von Willebrand disease, we can now discuss the various types of the von Willebrand disease. Okay, structural, qualitative, or quantitative abnormalities from the name. Either it's as a result of abnormalities in the cDNA sequence mutations, or is as a result of quantity, okay, reduced amounts, okay, abnormalities of the von Willebrand factor. So the von Willebrand disease is as a result of deficiency or dysfunction of the von Willebrand factor gene. Okay, reduced platelet adhesion, which leads to mucocutaneous hemorrhage of varying severity. Okay, so any abnormalities in von Willebrand factor can result in reduced platelet adhesion. You should be able to explain that very well. And this can lead to mucocutaneous hemorrhage of varying severity, because the process of primary hemostasis will not occur or will not come into completion. It can be epistaxis, ecchymosis, menorrhagia, gastrointestinal tract bleeding, hemoptysis, surgical bleeding. Okay, symptoms vary over time and within kindreds, because von Willebrand factor production and release are susceptible to a variety of physiological influences. Okay. Severe quantitative von Willebrand factor deficiency creates, in addition, factor 8 deficiency owing to the inability to protect non-bound factor 8 from proteolysis. Okay, so you see that another layer of severity can be added, because factor 8, which also plays important role in secondary hemostasis, which von Willebrand factor tends to protect in the plasma and extend its half-life. This function may not be able will not be carried out, okay, exposing the subject to more severe bleeding, because when the process of secondary hemostasis are also affected, there will be a more severe outcome. When factor 8 level decrease, because this will lead to the elimination of factor 8 faster from circulation. When factor 8 level decrease to less than 30% of normal, anatomic soft tissue bleeding accompanies the typical mucocutaneous bleeding pattern of von Willebrand factor. So depending on the level of decrease in factor 8 can dictate the severity of the von Willebrand factor. Now, there are types of von Willebrand disease. we said we have the qualitative, then broader classification. We have the qualitative and the quantitative. So the quantitative has to do with the amount, the level, the plasma level, the amount, the quantity that is present. They are functionally okay, but the level is low. So we have the quantitative and we have the qualitative type of von Willebrand factor. And majorly we have type 1, type 2, type 3. So type 1 and type 2 has to do with quantitative deficiency of von Willebrand factor. Type 1 has to do with a partial deficiency of von Willebrand factor. Type 3 is near or complete absence of von Willebrand factor in an individual. While type 2 von Willebrand disease has to do with the functional qualitative type of von Willebrand disease that are sub-classified into what we're going to see later. So this is the sub-classification of von Willebrand disease that we classify them into quantitative and qualitative type. Okay, that the quantitative type can absolute or near absence. You can't even see von Willebrand factor in somebody's system. Type 3, very severe, or relative partial deficiency. We call it type 1. Okay, under the qualitative von Willebrand factor disease, we have the structural or functional, either structural or functional. All of them results in type 2 von Willebrand disease, which are subclassified into type 2A, type 2B, type 2M, and type 2N. Okay. Type 1, we've already established that it's a quantitative von Willebrand factor deficiency. Type 1 von Willebrand disease occurs as a result of quantitative deficiency, partial quantitative deficiency of von Willebrand factor. It occurs in 75% of people or persons with von Willebrand disease. It affects any race, any sex. It's autosomal dominant with 60% penetrance, predominantly D3 point mutations, reduced production or release, increase it's as a result of reduced production of von Willebrand factor or reduced release of von Willebrand factor or increased consumption. Okay, so plasma von Willebrand factor concentration 20 to 50 units per dl. Von Willebrand factor antigen and resuscitin cofactor proportionate reduction. These are functional assay of von Willebrand factor. Multimers appear normal, not required for the diagnosis of type 1 von Willebrand disease. Okay, factor 8 activity is reduced. Okay, the factor 8 von Willebrand antigen ratio is 1.5 to 2. Okay, mild to moderate reduction. Variable effects on APTT and seldom contributes to symptoms. Autosomal dominance, 60% penetrance, we said that earlier. Okay. So in some situations, it may not really be type 1 von Willebrand disease. In some situations, it may be that an individual just have low von Willebrand factor. So they say that when von Willebrand factor is less than 30, normally diagnosis of von Willebrand disease type 1 is consistent. When it is between 30 to 50, diagnosis may be von Willebrand disease or low von Willebrand factor. Potentially 7.5 million US residents have this type 1 von Willebrand disease. Often no mutation can be detected, no family history pattern, and majority of these people that come down with von Willebrand disease type 1 are of blood group O. Okay. So we have von Willebrand disease subtype 2A, qualitative variant. These are the type 2 von Willebrand disease, which we are subclassified into type 2A, type 2B, type 2N, type 2M. So we're looking at type 2A. There are other subclassifications even under these types. As technology begins to improve, evidences of other types also continues to come. So it's amounts to 10 to 15% of von Willebrand disease, this type 2A. It has present with moderate or severe bleeding. Okay, there are hundreds of dominant mutations in individuals with this type of von Willebrand disease. Okay, large and intermediate multimers are absent. Okay, there are mutations in the D1 region of the von Willebrand factor domain, poor multimer assembly, small multimer bands with no satellite bands, 2 domain point mutation interfere with folding. These are the molecular changes that happens. Okay, so for type 2 von Willebrand disease, there are mutations at the A2 domains, okay, which interferes with folding. Okay, exposing this tyrosine methionine sequence to ADAMTS13 for cleavage and consumption. So it occurs as a result of interference in the folding of the von Willebrand factor, which exposes this sequence for cleavage by ADAMTS13. This is at the point where ADAMTS13 cleaves von Willebrand factor at this tyrosine 1605 and methionine 1606 points. Okay, so these points are being exposed for cleavage in 2A. Increase large multimer digestions. A lot of multimers, von Willebrand factor multimers are being cleaved. The cleaving is what we call the digestion. Okay, so that when there is multimer analysis, you see small bands of the protein, that is satellite bands, in the absence of shear stress, that is without any shear stress, like how when blood passes through the blood vessels, the force that is exerts for the blood to pass, it can lead to all this uncoiling of the large multimers of von Willebrand factor, exposing it for the ADAMTS13 to cleave. But in this situation, there are no such physiological mechanism of shear stress that is causing the exposure. No, without any shear stress, you find this satellite bands, this breakdown, smaller multimers of smaller bands of von Willebrand factor. Some mutation both really reduce the assembly and expose von Willebrand factor to digestion. So the antigen to factor 8 ratio can remain normal or they may be slightly decreased. These are functional assays when we want to evaluate von Willebrand factors in the lab. These are some of the assays we perform: resuscitin cofactor assay, collagen binding assay. These are functional assay of von Willebrand factor, and we say that resuscitin cofactor assay, collagen binding activity are disproportionately decreased. So once again, this is the von Willebrand factor multimer domain, showing us again the points, places of mutations, abnormalities in the molecule of von Willebrand factor that can result in any of the types of von Willebrand disease. This is, at this point, we are having abnormality in von Willebrand factor binding to factor 8, which will result in type 2N. We have not treated that one. Okay, at this point, we are having glycoprotein 1B heparin collagen abnormality binding to the A1 domain, which will give us 2B type and 2M type von Willebrand disease abnormality at the A3 domain of von Willebrand factor gene interfering with collagen binding can result to, okay, A2 can result in 2A. Okay, glycoprotein 2B and 3A, can see it here at C1 domain. Okay, so for von Willebrand disease type 2B, okay, it constitutes, or it account for less than 5% of the total von Willebrand disease we have. Okay, so it's smaller. Okay, mild to moderate bleeding occurs. There is increased von Willebrand factor affinity to platelet glycoprotein 1b. So the mutational change that occurs in this disorder makes von Willebrand factor to have more affinity for platelets, like those binding platelets unnecessarily. Also, like 2A, disproportionate reduction of von Willebrand factor activity, resuscitin activity relative to antigen ratio. Okay, more than 25% dominant gain of function of A1 point mutation, large multimers are absent. Okay, produced normally but cleared by platelets. Because of that much binding of von Willebrand factor to platelets, there's increased proteolysis. Intermediate multimer remains, no satellite bands. So this disorder results in affinity for platelet glycoprotein 1b, causing a loss of platelet adhesion to von Willebrand factor. Also observe mild thrombocytopenia, of course, because the platelets are being consumed in the process of binding with the von Willebrand factor. Okay. So we have von Willebrand disease type 2M. This type is rare, also present with mild to moderate bleeding. Okay, dominant A1 point mutations, decreased VWF affinity to glycoprotein 1b. Type 2B is increased affinity to glycoprotein 1b. Type 2M is decreased affinity to glycoprotein 1b. So unlike 2A, large multimers are present because the von Willebrand factors are not being consumed in adhering with the platelets. So the multimers are there. Okay. When we carry out electrophoretic analysis, we'll see the large multimers. They are there. Like type 2A, disproportionate reduction, of course, the platelet, the von Willebrand factor function assay. Subtype 2M may be diagnosed as type 1. Okay, resemble platelet type von Willebrand disease. Okay. Okay, subtype 2N. We are just trying to describe these types of von Willebrand diseases briefly, and how to distinguish each one from the other. Normandy, or also called Normandy, it's quite uncommon, present with moderate to severe anatomic bleeding also. There is a reduced factor 8 von Willebrand factor binding function. That is the binding of factor 8 to von Willebrand factor. It's reduced because of this mutation. Okay. It is autosomal recessive. Autosomal recessive. So 15 mutation at amino acid terminus, okay, have been described. Most prevalent mutation is arginine glycine with minimal symptoms. Suspects when factor 8 is deficient in a woman. Okay, when a woman's level of factor 8 is low, we have to screen for or determine whether it's whether is there a carrier of hemophilia or is suffering from type 2N von Willebrand disease, or when factor replacement is ineffective. Because if someone lacks factor 8 and factor 8 is being given, it is expected that there will be improvements in the clinical presentation of such patients, but sometimes it may be also as a result of inhibitors. So that is why for type 2N, how we can exactly fully evaluate it and clearly say that it is type 2N is by genomic sequencing the gene of the von Willebrand factor genes, the region of where von Willebrand factor binds to factor 8 to see if there's any genetic abnormality, this gene mutation along that pathway. So these are some of the, okay, this is just a diagram showing the multimer presentation in this, in some types of von Willebrand disease. You can see type 3 von Willebrand disease, where we say there is almost complete or near absence of von Willebrand factor. You don't find any von Willebrand factor multimer. You find where we say about type 2B, okay, type 2B, where there is increased affinity for platelets, okay, where there's increased affinity for platelets. Type 2A, okay, you can see the multimer is less. Then type 1 von Willebrand disease, can also see that the multimer is also less with satellite bands, okay. I think we have, okay, this is a gel image showing the multimers, von Willebrand factor multimers. So type 3 von Willebrand disease, von Willebrand factor is undetectable, very difficult to detect. It is an autosomal recessive nonsense and frame shift mutation. It's an autosomal recessive disorder where we have a lot of types of mutation that are being referred to as nonsense and then frame shift mutations. These are types of molecular terms to describe the type of changes that occur in a sequence of a gene. Okay, majority of them are heterozygotes. Heterozygotes of them have 50% von Willebrand factor, but no symptoms. You have those that present with homozygotes or double heterozygotes, von Willebrand protein activity and protein and activity also may be absent. Factor 8 is 1 to 10%, very low. Anatomic and systemic bleeding can occur, occurs, not can occur. Then there may be antibodies or replacement treatments. Okay. Okay, this is just a diagram also trying to show the multimers of von Willebrand factor. All right. Thank you. The only person that remains on this lecture now is Ichukwunoye. Okay, thank you for your time. Any questions now you can ask. Okay.